Okay. Well, I want to introduce our next speaker, and this is Dr. Jane Schubart. Dr. Schubart is an associate professor at Penn State College of Medicine, and her research focuses on the health outcomes after surgery, with a particular interest and emphasis on complex care and complex chronic illnesses. Since 2015, her work has included extensive research in heritable disorders of connective tissue, including the Ehlers-Danlos syndromes, and she draws data from a major study from the National Institute of Aging cohort study. So please help me welcome Dr. Schubart. Thank you.
First, I'd like to thank Dr. Knight for inviting me. I went to school here. I lived here for 20 years. So I just think there's a lot of hope right here at the University of Virginia. So I'm really proud to come back and visit. It's kind of bittersweet. So I'm an outcomes researcher, and I work in the Department of Surgery. We're a very large department with lots of divisions. We do not include orthopedic surgery, so I thought I'd talk about orthopedic surgery, okay? Because I think I know a little bit more about orthopedics than I know about other things. I've been working with the Ehlers-Danlos population, I guess 11, 12 years. It all started when I met Dr. Frank Amano and Susan Mills, who's here with me and has been from the beginning, and went to one of the big society conferences and met lots and lots of patients. And really, right from the beginning, I was hearing stories about the number of orthopedic surgeries that patients have. And patients have, I know lots and lots of patients over the years, and I may speak about a few of them. So I just want to start with one paper that I found interesting. This was a retrospective analysis of 350 patients, of which over a third had EDS at one institution. It included a comparison group, but I think what struck me with this is the conclusion that patients with hypermobility had more surgeries. The relative risk, that's the RR, was 3.5 times that of the comparison group. And, they had multiple joint sites. They would have multiple surgeries on the same joint, surgeries on different joints, and at a younger age. And I really wanted to understand, I was hoping I could understand why, what was going on exactly. Whoops. Back up. So then the second paper, there are a number of good background papers out there, but the second one that I wanted just to point out was done, this is the Yonko paper from 2021. The senior author on this is Kathy Raggio, who chairs the Orthopedic Working Group for the International Consortium. She's at the Hospital for Special Surgery in New York City. And they did a retrospective chart review of 150 patients and found, as you'll see, a 91% complication rate. That is not a typo, 91%. And their infection rate was more than 18 times the baseline infection rate. And HSS has one of the lowest, if not the lowest, infection rate in the country. So I found that striking. So anyway, I was motivated to dig into the literature. So we did, ideally, I'd like to do a meta-analysis where you kind of pool all these good studies together. And so you have a great big sample size and we can do meta-analysis and those kind of techniques, because that's something like I like to do. But you're going to see what we found in the literature, what's published. Scott Rodeo is at HSS. He is a shoulder and knee surgeon, and he kind of kept this train on the track for me, so I didn't say anything too foolish. And anyway, we did kind of the standard big database lit review from the beginning of these databases through February of 2024. And this is how we organize it. So for a paper to be included in the study, we were looking at, obviously, Ehlers-Danlos syndromes, but any age or sex. They had to be studying orthopedic surgery of shoulders, knees, hips, the spine. You can see that, elbows. What we left out, we excluded neurosurgery procedures that involve the brainstem. Um, why did we do that? Well, I think what we were trying to do was big enough. And the neurosurgery, that just seemed to be different. And it was just the way I did it. So that's my justification. Now, the studies did not have to have a comparison group. If they did, we recorded it, but they did not have to have that to be included. But they did have to have some type of outcome, whether short term or long term. So this is the most important slide for this part of my talk. We ended up with 71 citations that we were able to include, published through 2023. And this is what's important. Look at the type of studies. 38 were single case studies, like one patient, okay? 14 were small case series, several patients. 19 were retrospective, looking back in time cohort. No randomized clinical studies. There were some database studies, no systematic reviews. So not a whole lot out there, right? I couldn't do that meta-analysis I had hoped to do. But there were, and some of the other limitations were that most of these studies lacked standard validated measures when they were looking at the outcomes. The criteria, in fact, used for the diagnosis was not even stated. They just were patients who had EDS. We don't know what type, and we don't know how that was assessed. Uh, and the follow-up periods varied both between the studies and even within studies. So in a case series, maybe some patients were studied for 3 months, for 6 months, for a year. It was all over. It was just all over the place. The key findings, we did not find convincing evidence to support the long-term success of orthopedic surgery in EDS. Now, let me say that again. We didn't find the evidence. That doesn't mean it's not there. We just didn't find it in the published literature. Now, again, most were case studies, and I don't want to discount case studies at all because I think they're really important. So if you're doing that kind of work, if you're a clinician, write about it. Get it out in the literature, even one patient, if it's interesting and different. But most of those papers tended to focus on surgical techniques or challenges that might be specific to EDS. Again, very important. So in summary, I guess this high level summary were, high rates of subluxations and dislocations, pain that may require surgery. If non-surgical interventions fail, surgery was considered to be, a last resort because management, as you know, is challenging. And as we know, these patients often have multiple unsuccessful surgeries. And again, the literature is sparse, so I'm hoping more orthopedic surgeons will be inspired to do this. Okay, I'm going to shift gears because I like data, and this is something I did a couple of years ago with a big database called MarketScan. At the time, it was owned by a company called Truven. It has since sold and is now Meredith. This is a very large commercial claims database with over 230 million patients. Now, also, all databases and studies have disadvantages. This one, it includes patients, this is employer-based health insurance, their spouses and dependents, okay? So we're leaving out a lot of people. I did not look at Medicare, I did not look at Medicaid, the self-pay. This is an insured population, but it's very rich in that it has inpatient, outpatient. The drug detailed pharmaceutical claims are terrific, and I've done a number of patients, of course, never by myself, but with my colleagues using this database. So I looked at this one a little differently. And usually when I use big databases, my first thing is sort of to code and to collect all the EDS patients. That's my big pool. Then we dig into that and we begin to do our studies. But with this one, I went after all the surgeries that I was interested in. Okay, so, and I used the CPT procedure codes or diagnosis codes. And so that was the time frame, 2005 to 2019. And you can see I looked at a whole lot of things. I'm going to just talk about the first bullet, the orthopedic, but I have the data for all of this. And I never published this. So, and I've never presented it. It's, I'm not sure why. It's in a pile. But so in MarketScan, the patients had to be enrolled. They had kind of a washout period prior to their surgery, and then for at least 6 months after surgery, because I want to look at outcomes, right? And you can see I looked at a lot of different diagnoses. After we had our big pool of the surgeries, then I looked at EDS and Marfan and skeletal dysplasia and all kinds of things. Because if you're going to get all this data, you may as well code it all. I did do all the comorbidities. I'm not going to talk about that because there's been a lot of discussion about comorbidities. I'm going to tell you the results in terms of complications, but I'm just going to show this busy slide real quick because I code everything. I use, we're going way back in time. So we have some that are ICD-10 codes, and then we use the current, ICD-9 codes, and then we use the current ICD-10 codes to code complications. And then I look at outcomes. That's what I care about. So in Market Scan, we can look at readmissions, inpatient readmissions. That's for any reason. I never know why a patient was readmitted. So again, here's a downside to using this large database, but the advantage is it's really big. I look at emergency department visits, repeat surgeries within the same categories, or second surgeries that are not the same classification. And then we look at 30, 90, and 180 days after the index surgery. So for EDS, there were 1,280 patients. If I add in HSD, I usually about more than double the sample size. So I'll just make a quick comment. I typically look at both, but I've coded. There is not a diagnosis code for HSD. There's never been that. Okay, so that's a big problem for me. I use a proxy. I use M35.7, which is hypermobility spectrum, but that can include all kinds of things. So we never really know. So if I combine it, I always analyze them separately. Now, from here forward, I'm just going to talk about EDS because I just feel like that's clean. Because we have such a huge database, we can match one-to-one, that's good, on age, sex, and an index date. And this is the last slide on this. I just want to point out some of the results that we found, which I thought were pretty interesting. You can see the control group. Now we match, so I have controls. What are controls? I don't know if they're healthy people or not. I just know they don't have EDS. Okay, that's the way we define that. Compared to EDS, and then whether they were statistically significant in terms of the differences using, this is chi-square. So the ones I think are the most interesting are down a little towards the end. The emergency department visits, we're more than double on a lot of these things between EDS and control. So maybe there's kind of something there, but I don't really know why they went back to the ED, why they went to the ED. I don't know. Maybe that's why I didn't publish it. So let me just move on from that unpublished study. I want to tell you about Penn State, okay? Because and I'm going to let the data tell the story of what we are doing at Penn State Health in terms of EDS. Okay, just this is the data talking to you, me telling you what it says. So first of all, a high-level view of Penn State Health. Kind of your standard stuff there at the top. The flagship hospital is in Hershey, 631 beds. That's where I work, in Hershey. We have a large catchment area in central Pennsylvania. We've been buying hospitals, so we have multiple hospitals, but Hershey is the main place. We serve a core of about 6 counties. And then but we really have a large catchment of 15 and even more for cancer. So we're serving a large area between Pittsburgh and Philadelphia. Okay. So I pulled this data. Now this is coming from our our system data. I get the IT people, I get them to convince them to help me. So we were able to we have Cerner, by the way. We're switching to Epic soon, and I'm told I won't get this kind of data, but they gave me 25 years of data looking at the EDS patients that we had seen. Now, I'm going to restrict this to just patients that I coded as having orthopedic or neurosurgery procedures. So this is a subset, but you can see the trend line there. We're seeing more every year. So since 2022, because I'm going to kind of lop that off and look at what's really going on now, 638 active patients, and if we keep going at the rate we're going, and I just sort of project that out, we will see 580 unique patients this year, and that isn't even everybody. I'm not including. I know we've got PT here. I'm not able to capture our physical therapy Just I won't get into that, but just we're kind of different organizationally, so I don't have access to that. But the top 10% is accounting for 10 to 36 visits each, kind of reflecting people that are requiring frequent procedural interventions. So I was trying to get a sense from the data, who are kind of the one-time people we see, who are we seeing repeatedly. I have a lot of data I could wade through and look at that. I also said, well, what are we doing? Like, who's doing what? And we do all kinds of things: spinal surgeries, infusions, diagnostics, injections, some surgery, hip replacements, and so on and so forth. And well, I'll keep going with that. Length of stay, though, this is kind of interesting, right? A 9.8, almost a 10-day length of stay. That's very high. That's not where we want to be. But and for a standard orthopedic joint replacement, I mean, honestly, some of them are like, hey, you got a new hip? See ya. And it's same day, truly same day surgery. But 2 to 4 would be a standard for somebody a little more complicated. So this 10-day is reflecting the complexity of some of the outlier type patients. This is a little bit, but wound rates of wounds and other complications are the reasons, in some of the cases, for the extended stay. But our top procedures are mostly injections, and that clinic and that same day surgery are representing the vast majority. Physical medicine and rehab has by far the highest volume. And the way I'm going to characterize is, are we a center of excellence? Uh, not in the sense of an organizational infrastructure. There's not been that organizational initiative. We're kind of, I call us, we're like a stealth center. And we are rapidly expanding. And I feel like, why? Because patient demand for surgery, the patient demand, the patients are coming. And most important, we have a core of just dedicated, fabulous, wonderful people who are willing to see people with EDS. And the word gets out and they come. And that's what's going on. What hasn't happened yet is the organizational infrastructure to support that. And what do we need? We need money for that. But if you call and try to schedule and say, now, does you call who sees EDS? They can't tell you. They can't tell you. It's not that they won't, they can't. Well, I mean, I suppose they could. So we got a long way to go. Um, so the other thing I'm going to switch, kind of wind up with this part, thinking about perspectives of orthopedic surgery. And the thing I think about is, how do we measure success or failure? It's a complex thing to measure, but I think it's really important. So is success a decrease in symptoms or an absence of symptoms postoperatively? For somebody like me who likes to look at data and decide, where do we go from here? How are we doing? Um, success is going to be important. And I feel like there are different ways we can capture that. And one is the patient's perception, and then also the surgeon, and then both is what we need. So, okay. This is ongoing. I'm going to call it a pilot, but I have put this out, and I think, Dr. Knight, you've sent it out to your team. Let's push it out again. We're in the early stages here. I'm just going to show you 2 screens. This is an online survey. I'm really asking physicians who, they don't have to be surgeons, but orthopedic physicians. So maybe they're doing injections or whatever. But I'm really interested in, what are they concerned about when they evaluate somebody with EDS? I ask a lot of questions, about the kind of practice and how many they see and so on and so forth. But what are they most concerned about? And what has their experience been? And does perception match reality? And I'll tell you real quick, one thing that kind of drove me to this. I heard from a patient, it's been some time back, who actually went to our own orthopedic department and was turned away. And by an orthopedic surgeon, it was like, don't do EDS, can't help you, don't do EDS. And you don't like hearing that, and kind of angry on the one hand, but also, why? Like, why? I mean, maybe there's a good reason, right? We need to understand why what's going on here. So this is sort of maybe my attempt to find out. Now, surveys. I don't know. Has anybody done survey research? Good. Okay. So we've done Susan's terrific at this, and we did some surveys, a number of them, but we did one fairly recently with patients. Now, I asked these patients, this was an economic survey, very difficult. I asked them to go back. They had to stop. They had to go get their records, how much money had they spent, get out your tax returns, get out and then answer all these questions and how much did you spend on this and this and this and this, and it probably took quite a bit of time. And we didn't really have to push too hard. I got 1003 responses, right? That's published if you're interested in it. Um, this so far, I have 17. I was warned. I was warned. Jane, you're not going to get surgeons and physicians to fill in survey. And I totally get it. I totally get it. We're all overwhelmed with surveys and it's difficult, right? But we're going to keep pushing, right, Dr. Knight? But I will give you a little, I'm going to like a little, just one teeny bit. This may bias anybody who takes it, but the one thing, this is looking at patients, and then I ask, is it different with EDS? But what are the most important things to consider in their recovery? And coming through really strong is that 13D, the expectations of the surgery, expectations for recovery, expectations of what. So I found that kind of interesting. We'll see what it looks like when we get more responses. Okay, I did one more study and it's one patient. Thought I have lots of people I could talk to. I want to kind of wind up with this because I want to come back to the patient and the patient perspective on this because that's really where it started. So I have a lot of patients, a lot of people, and I thought, maybe I could get some patients, maybe even one to kind of talk to me. And I truly randomly just picked somebody. I wasn't even sure that she had had surgery, but she had, and she was willing to talk to me. She talked to me for an hour. She, female, age 50. She actually has classical type. Typical story, I guess, if there is a typical, but you've heard the story. So, very athletic person. I think she played softball and lots of sports. But along the way, had lots of sprains and so forth and so on, like we've heard today. And then she had a car accident, very serious car accident. Maybe that was that event, Dr. Frank, am I right? That precipitating event, because from there, a long recovery, very difficult recovery, and she was diagnosed 2 years after that at the age of 34. But the reason that she was diagnosed was luck, because she had a neurologist taking care of her as the result of some of this injury who had just happened to read about EDS and took an interest in it. She had, and then over time, she had both ankles. She had surgery on both ankles, braces to tighten things up, a revision on an ankle due to an accident. She fell. She had a knee done, both hips for frayed labrum, both elbows have been done, and a whole bunch of other procedures and things for various other orthopedic conditions. So she's had a whole lot done, a lot of things done. I don't know how typical that is or not because I haven't, done that. Maybe somebody else could do that. So my final thing in asking her, I said, you know, do you consider your surgeries a success? And she said, without hesitation, yes. She'd had one wound complication on the ankle that was treated at home with a wound kit. She had a successful revision. The fall was due to having POTS. She got dizzy and fell. And then I asked her about other thoughts. What else should I say? What else can I, what else is really important? And she said post surgery, that she said, tell everybody the post op visits are simply not sufficient for EDS because the healing process is longer. And to recommend additional visits, with the physician assistant, and also tailored protocols for EDS, even by week. What should I be doing each week? and you need a longer time frame, and you need you need more visits. And her other point was that not all symptoms are due to EDS. Okay, because she had some experience where she had pain and some symptoms that should have prompted imaging. Physician sees the EDS diagnosis and says, it's your EDS and don't worry about it. And it wasn't. So in conclusion, the outcome studies are very important, I think, to ensure both surgeon and patient expectations and help guide shared decisions. And then, as we've heard, education and expertise. So I think we need to get the word out to our surgeons as well. I did some time back, and oh, so my work has been, had some support. I'm grateful for any and all support, and it's honestly never enough to do all that we want to do. Um, but let's get the word out to our surgeons.
Getting a little agita. So I've referred patients for surgery.
Okay.
And had the surgeon say, EDS, I don't want to touch it, right? And for reasons that are not entirely clear, I'd be questioning as to how to do that. But one thing is the economic stuff. If the payers bundle the payment, we're going to, for every joint replacement, we give you X amount of dollars, which is what most of the payers do. If EDS patients have a longer recovery time, greater complication rate, et cetera, the institutions might actually lose money on those procedures. So we haven't really talked about working through the CMS. And, all the payers tend to follow what the CMS says. But if the CMS says, we're going to pay you more money to do procedures on EDS patients because they cost more money to do those procedures because they have more complications, et cetera. So that might turn that around. So do you have a sense yet? Is the problem ignorance? They don't know what the problems are? And then you seem to be suggesting that maybe they're smarter than we think. They know that there's more complications. And then what do we do with payers?
That's an excellent question. So why, I guess the question, why are surgeons reluctant to see EDS patients? Is it because of complexity, ignorance, or because of bundled payments and that the institution could lose money on it? I'm trying to paraphrase your question. I don't think it's economics, not yet. I don't get that sense, not where I am. I think it may be they just don't know that much about it, and its complexity, and they're time consuming, but they don't want a bad outcome. Nobody wants it, you get dinged, right? You get dinged on bad outcomes, so don't want a bad outcome. I gave a number of years ago. It's been quite a while in my department. We have to take turns giving, what grand rounds is. So that's like where you stand like this in a much bigger, and it's kind of a hostile group in the Department of Surgery. It really kind of is. Nobody's laughing or smiling. You don't get that feedback like you guys are great. So I did talk about surgical outcomes in general surgery, and thankfully I didn't realize at the time what my audience, but I was told I was really, really brave to talk about EDS to a group of surgeons. That's been a long time ago. I don't know that I would do it again. Maybe I would. Anyway, was there
any more questions? Yes.
Stated that patients with joint hypermobility have consistently worse surgical
Not
Jane, can you repeat?
okay. So she's asking. The question is about ankle surgery, and a physician that has questioned whether the outcomes are good enough in using standard ankle kind of surgery procedures. Is there any work to do, more specific, different types of procedures for ankles? Some of the I don't know specifically about ankles that have been published, but I do think that like some of the mechanisms, the hardware that will, like that will anchor things, because what's going on in EDS, it's typically these ligaments are stretching. Okay, it's not like the bones so much as it is the stretching of the ligaments. And so that can like be tightened up, but then what happens is it stretches out again and it goes back. So it's not as successful. But I think that there are not the studies, which I had hoped to find, to look at do standard procedures for other patients work in EDS? Or are there modifications that are needed specifically for EDS? I mean, with some things like, some of the other complications like sutures don't stay. So yeah, right. So suturing techniques, they may be more difficult, but they're certainly doable. But the surgeon needs to be aware of that. Even in my department, I mean, we have, people with EDS have all the other same kind of stuff, right? Coming in for surgery where sutures are a problem, wound healing needs special care. Hardware may be rejected or kind of move around. That's another thing. Hardware failure is a big thing. And that's a pretty bad outcome because, you have to take it out, redo it. So no, there needs to be more work to understand this.